Total knee arthroplasty is a clinically successful and cost-effective treatment of advanced knee osteoarthritis. And primary TKs have 10-year survival rate of 95%. All of us know that. It's nothing new. It's a successful operation. But as the numbers started growing up, we started facing newer and newer problems. I would like to bring to your attention a couple of problems here. The first is that as the primary TKs go up, there is steady rise in the volumes of revision TKs in the recent years. And half of them are done within 2 years of index TKA. So it's a very dangerous situation. And in half of them, the reasons are malalignment, malpositioning, instability, or fixation failure. Another set of patients are unsatisfied patients. Various series show that up to 20% of the patients remain unsatisfied in spite of doing excellent surgery. Why? What are the reasons? There are patient-related reasons and surgeon-related reasons. We'll forget about the patient-related reasons. The surgeon-related reasons are malpositioning, wrong sizing, instability, stiffness, maltracking, and infection. So, to get a successful result, it is very important to align your limb properly and to position your implant properly. And it has been seen proved in various literature. It is showed that failure rate significantly increases if there is more than 3 to 4 degrees of varus or valgus malalignment. And range of motion decreases by 20 degrees, even if there is just 2.5 millimeter of difference in AP positioning of femoral component. Restoration of joint line and restoration of physiological kinematics is very important. Partington and others have shown that elevation of joint line by 8 millimeters correlated with worse clinical outcomes. And Martin and Whiteside, in their cadaveric studies, they showed that positioning of femoral component 5 millimeter proximal and 5 millimeter anterior leads to significant mid-flexion instability. The navigation helps the surgeon with objective intraoperative data that can lead to more consistent alignment and stability. Now, all these things are always compared with conventional instruments or manual instruments. How good they are? The manual instruments are as good as surgeon. Mihalko and Krakow published their studies in Journal of Orthoplasty, and they showed that there are a lot of variations in starting position of femoral intramedullary alignment rod, which leads to wrong distal femoral cut and varus and valgus malalignment. There are variations in tibial cuts also. They did one study where they asked experienced surgeons to mark epicondylar axis, and they found that up to 7 degrees of differences in various markings. And that leads to wrong placement of femoral component in transverse plane. And all these things can lead to malalignment and early failure of the joint. The navigation gives an advantage of accurate and reproducible technique. The coronal plane alignment is within 3 degrees of anatomical axis. There is less chances of bleeding, less fat embolism, better soft tissue balancing. However, there are certain disadvantages. Sometimes it takes longer time, but with experience you can reduce it. It is expensive. In osteoporotic patients, you may get fractures through the pinholes. And again, it's a computer. If you feed wrongly, you will get wrong results. All these things have been validated in various studies. To quote you one, Zhang and al. Published in 2011, that navigated TKA have been demonstrated to provide more consistent coronal plane alignment within 3 degrees of anatomical axis compared with standard technique. And large RCTs found mechanical outliers in 28% of conventional group as compared with 0% with navigation group. So it is proved beyond doubt that navigation gives an excellent alignment and proper positioning of your implants. Now, whether that is true in clinical practice, because that is very important for all of us. Our patients should get good result. Let us see what the literature has to say. Harney and others published in 2011, they studied 777 cases in single arthroplasty center and found that there was no difference in 5-year outcome, though the alignment was good. Schuner and al. Studied revision rates of more than 1,000 knees with a follow-up of 1 to 6 years, and they found that the revision rate was greater in conventional group than in navigation group. Yaffe and others in 2013 concluded that there was no significant difference in clinical or functional outcomes between navigated and conventional group except for post-operative mechanical alignment at 5-year follow-up. Jela and Chawla did systematic review of more than 4 lakh patients, and they found that there was no significant difference between navigation and conventional if you just use alignment and component positioning for your data. However, if you add to it ligament balancing with proper tensioners, the results were far, far superior. And this is a recent from Journal of Arthroplasty, July 2018, Jones and Jaravec. They concluded that navigation certainly improves the accuracy and precision of component alignment in TKA. However, there is no proven clinical superiority over conventional technique. So at present, the literature doesn't support the use of navigation in each and every case. So what is the present situation in 2018 where one should always go for try to use navigation? Clinically, I feel in primary TKAs there are 3 situations where one must try to use navigation to get better results. First is severe varus deformities more than 20 degrees. Severe valgus deformities, these are very tricky deformities and not very common, and one needs to have experience to correct it. So it is always better to have navigation at your help. And third situation is extra-articular deformities, either because of malunited fractures or because of the osteotomies. These are the 3 situations where I feel that one must use navigation. I would like to conclude by reading out a beautifully written passage from Professor Cho's book. He says that with the help of navigation surgery, accurate placement of implant and restoration of mechanical axis is possible. However, it is uncertain how that reflects in clinical result. The concept of navigation should be understood as a type of surgical tool that helps the surgeon to perform the surgery accurately. Navigation cannot satisfy the surgeons who believe that it's an art. Sometimes a beautiful painting can be more impressive than a photograph, or a well-made handicraft can be better than a machine-made part. Choice is yours. Thank you very much.